Do you hear me?
Yes.
Yes, yes.
And do you see me?
Of course.
Thank you. Okay. Excuse me, I couldn't do it on full size.
You can try to press F5.
F5. I try to do it.
What is one here?
Okay. Dear Chairman, dear colleagues, let me present you the results of study of left ventricular mass and inflammatory markers at 2 years after the renal denervation. Despite the progress in the development of antihypertensive pharmacotherapy, the prevalence of uncontrolled arterial hypertension is still very high. Major classes of antihypertensive drugs can reduce blood pressure on average by 9 for systolic and 5.5 for diastolic blood pressure when administered as monotherapy, and about 30 and 15 for systolic and diastolic blood pressure when 3 drugs are used in combination. It's obviously not enough for effective treatment of severe arterial hypertension. According to large meta-analysis, the left ventricular hypertrophy is diagnosed in 55–75% of patients with severe arterial hypertension. Its high prevalence is associated with cardiovascular disease morbidity and mortality, myocardial infarction and its size, stroke, heart failure, and cardiac arrhythmias. A role of inflammation in the development of hypertension and hypertensive organ damage has been widely discussed in recent decades. Elevated levels of pro-inflammatory markers was shown to contribute to end organ damage in subjects with hypertension. A variety of pro-inflammatory and inflammatory factors have been studied for their relationship with the progression of a disease, especially high sensitive C-reactive protein, interleukins, and tumor necrosis factor. Treatment of resistant hypertension with renal denervation demonstrates a regress of left ventricular hypertrophy, but with low predictability, and even in the absence of blood pressure response. Although the long-term effects of renal denervation are not well studied. So the main purpose was to study the long-term effects of renal denervation on left ventricular mass and inflammatory markers in resistant hypertensive patients. We performed the retrospective analysis of the data from the single-center study of renal denervation in resistant hypertensive patients conducted in the Cardiology Research Institute of Tomsk National Medical Research Center. Study inclusion and exclusion criteria are well known. Patients meeting eligibility criteria underwent renal denervation and were followed up for a period up to 3 years. All patients were instructed to maintain the concomitant drug therapy as stable as possible during the follow-up. There were 6 12-month, 2- and 3-year follow-up examination to assess the safety and efficacy of renal denervation. The results of annual observation were presented earlier, and this study presents the research data from 41 resistant hypertensive patients who complete 2-year follow-up. Baseline characteristics and the structure of antihypertensive pharmacotherapy are summarized in a table. The following parameters were analyzed at baseline and 2 years after the renal denervation. It was ambulatory blood pressure, echocardiography, it was a high sensitive C-reactive protein and interleukins, tumor necrosis factors if they were measured in blood serum in the absence of acute inflammation or exacerbation of chronic pathology. Also, serum creatinine was measured too to assess the renal function. 2 years after the renal denervation, the ambulatory blood pressure was significantly decreased compared to baseline. The analysis of patients' reported data on antihypertensive drug use has shown no significant changes in concomitant drug therapy throughout the follow-up period. The baseline prevalence of left ventricular hypertrophy in a single study was 90%. The decrease of left ventricular mass was documented in 24 patients at 2 years after the renal denervation, and it decreased significantly mainly due to decrease of interventricular septum, whereas the power wall thickness didn't change. Regression of left ventricular mass was associated with significant decrease of inflammatory factors. So the level of interleukin-1 beta decreased by 70%, interleukin-10 by 60%, high-sensitive C-reactive protein by 40%, tumor necrosis factor by 60%, and only interleukin-6 didn't change. In contrast, there were no significant changes of inflammatory markers in patients in the absence of left ventricular mass regress. Only tumor necrosis factor decreased significantly by 70%. The likelihood of interventricular septum regress at 2 years after treatment was associated with baseline level of tumor necrosis factor and its dynamic at 2 years after the treatment, after the renal denervation. There was no correlation, there was no relationship between left ventricular mass regress and inflammatory markers. So the main finding of our study is that interventricular septum thickness and left ventricular mass assessed by echocardiography decreased significantly at 2 years after renal denervation. It means that renal denervation may have long-term cardioprotective efficacy, which at least in part may be attributed to the regress of systemic or myocardial inflammatory activity. In spite of research limitations such as small group and absence of control group, the results obtained are scientific interest and demand continuing the research. Thank you.